So we'll start with the management of community-acquired pneumonia. We all know that for us to manage a community-acquired pneumonia, first you need to be able to recognize CAP. So the diagnosis is very important. Then risk stratification, severity assessment, investigate wisely wherever it is recommended or required. And then, of course, starting the right therapy. So empirical treatment has to be appropriate and then reviewing at 48 to 72 hours. So treat the patient and the syndrome, not just the X-ray or the culture report, which is very important, which we always talk, like we've been saying, that you need to look at the patient's history, you need to examine the patient, and then, depend upon or look at the investigations. So how is CAP different? How is it defined? It is an acute infection of the pulmonary parenchyma acquired in the community and symptoms plus a new infiltrate on the imaging. So that is what essentially forms the definition of a community acquired pneumonia. So patient can present with fever, systemic illness, cough, with or without productive sputum, may have a pleuritic pain or dyspnea. When you examine the patient, you may find crepitations, bronchial breath sounds, uh, dullness or increased vocal resonance. If the patient has a severe disease, then he may present with hypoxemia, confusion, features of sepsis, or even septic shock. And when you look at the imaging, when you look at the initial chest X-ray, you would find a new infiltrate, maybe a unilobar or a multilobar disease, effusion, cavitation. So biomarkers alone should not decide whether pneumonia exists or not. It is a whole picture together, along with the presentation, the on examination, as well as the imaging. So what is the impact of this disease? Globally, about 2.6 million deaths have been reported, and patients who are hospitalized in the ICU, the mortality at 1 year is about 50%. And they also have increased cardiovascular risk. So, it is important to call your patients for follow-up because it is not just an acute infection. There are post-discharge consequences as well. So, at least in the initial phase, in the once the patient has been discharged, you must keep a follow-up of your patient. When you look at the Indian context, about 4 million community-acquired pneumonia cases have been reported, and ICU CAP mortality exceeds 30%. Remember, when you're treating an infection in the chest of a patient, you must not forget the possibility of tuberculosis in our country. It can present as a mimic, as a co-diagnosis. So do not just blindly copy Western empirical regimens, and you need to know your local antibiogram because that is very important right from the time you decide the initial therapy and to understand what your patient is actually requiring and is suffering from. Now, briefly at the pathogenesis, so microaspiration is the dominant route of entry in adults, and inhalation of droplets, infection by inhalation of droplets is seen in infections with mycoplasma, chlamydia, legionella, and as well as viruses. Hematogen is spread, although rare, but can be a cause of the infection. Now, a little bit about influenza and bacterial pneumonias. We often hear about the association of bacterial pneumonia, and this was quite extensively discussed in the module 4. So, influenza damages the mucociliary clearance and epithelial defenses. And secondary bacterial pneumonia can follow an initial viral improvement. So, when your patient has been treated for influenza, presents again in the hospital or in your OPD with symptoms like new fever, hemoptysis, or maybe a cavitation on the X-ray. So think of infections with Streptococcus pneumoniae, staph, MRSA, as well as H influenzae. And you accordingly need to plan and manage these patients. Then, in about 62% of cases, no pathogen is identified in the pneumonia patients. The common organisms that we see causing community-acquired pneumonia, typical ones are strep pneumoniae, H influenza, Moraxella catarrhalis, and the mainstay of treatment for these is your beta-lactams and beta-lactam is inhibitors. Then for atypical, there is the organisms are Mycoplasma pneumoniae, Chlamydophilia pneumoniae, Chlamydia psittaci, and Legionella. And remember that for the atypical cover, we can choose from doxycycline, macrolide, and fluoroquinolones. But in India, you know that there is a possibility of tuberculosis, and you do not want to use fluoroquinolones or overexploit fluoroquinolones as a drug of choice for your atypical cover. Over a period of time, it has been noticed that with macrolides, there is more resistance. About 50% of species of mycoplasma are resistant. So these days, more and more choice for atypical cover is with doxycycline. So beta-lactam is inhibitor with doxycycline becomes your ideal treatment of choice. And then, of course, there is a limited and a few patients who may have infections with community-acquired MRSA, hypervirulent Klebsiella, Pseudomonas, and Burkholderia. So this was published in 2019, and they had seen that there is, even in community-acquired pneumonia, there are risk factors for each of these drug-resistant pathogens. So this was the GLIMP study, and they'd seen that there was about 3% of MRSA infections, 4.2 of Pseudomonas, and 6% of Enterobacteriaceae. There are specific risk factors for each of this. And based on that, all this matters because if you have these specific risk factors, your empirical therapy of choice changes, or you add on these covers. So that is why knowing these uh, and understanding these is important. Now let's look at a case to understand further the management of CAP. So this was a 28-year-old previously healthy IT professional who presented with 4 days of fever, productive cough with yellowish sputum, and right-sided pleuritic chest pain. So essentially, his otherwise healthy, non-smoker, no comorbs, uh, no history of any recent travel. He was hemodynamically stable, not hypoxic. There were creps in his right lower zone on examination. And on the chest X-ray, as you can see, there was a right lower lobe pneumonia. So these were his labs. See if you can see them on the right side. So now the question was, where do you treat this patient? Whether you admit him or you treat him as an outpatient, and whether all these investigations that have been done, were they really needed? And what would be the ideal empirical antibiotic regimen of choice? So, there are various scores that are used in pneumonia. There are various severity scores that have been there. But the easiest one is the CURB 65 or the CRB 65, which involves the components of confusion, urea, nitrogen elevated, respiratory rate more than 30, systolic blood pressure of less than 90, or diastolic blood pressure of less than 60, and age more than 65 years. So based on the scoring of 0 to 1, outpatient, 2, observation or short admission, and more than 3, you admit in the ICU. So our patient, of course, was fit enough to be managed on outpatient basis. Now, when you're treating a patient of CAP on outpatient basis, usually clinical assessment and during the clinical assessment and proper examination as well as pulse oximetry is enough. You usually do not need to investigate or send extensive microbiology or biomarkers for a patient who's being treated on outpatient basis. Chest X-ray in cases when you think that the diagnosis is uncertain or you want to confirm the presence of an infiltrate. So generally, so much of extensive microbiology and biomarkers were not needed in this patient as well. Now, this treatment for the outpatient CAP is as per the IDSA and ATS, and patients with no comorbidity can be treated with amoxicillin, doxycycline, or a macrolide only if local pneumococcal resistance is low. With comorbidities, BLBLI, coamoxiclav, or a cephalosporin, along with macrolide or doxycycline for atypical cover. Like I said, respiratory fluoroquinolones, you want to not used for your patients for atypical cover because of the possibility of tuberculosis in our country. So, how would a practical approach or a prescription for your patient of CAP be? That you've confirmed the diagnosis clinically and done an X-ray if you thought it was really needed. You've checked the oxygen saturation levels, uh, done the CURB 65 criteria, and you know you're treating this patient on OPD basis. You've assessed for comorbidities, ruled out tuberculosis, or if influenza, if there was a possibility of that. Then, of course, you choose the right therapy, the empirical therapy that we were just discussing. You tell your patient when to return if there are any of uh, signs like persistent worsening fever, or he becomes more breathless, starts to desaturate, develops newer symptoms of hemoptysis, starts getting confused. And you want to do a follow up within 48 to 72 hours, especially for elderly and comorbid patients. So let's look at another case to further understand the management. A 68-year-old smoker with severe COPD on tiotropium and ICS-LABA presents with 3 days of cough, purulent sputum, breathlessness, and altered sensorium for 6 hours. He was brought in by his family, and as you can see, he's hemodynamically unstable even after 2 liters of crystalloid resuscitation, tachypnic, hypoxemic on room air, has bilateral crackles. ABG was showing respiratory acidosis as well as hypoxemia. So, and the X-ray is showing you bilateral multilobar involvement. So, this patient, in experienced hands and experts, there won't be a confusion that this patient has severe CAP and needs to be admitted in the ICU. However, ATS and IDSA have a criteria for ICU admission for severe CAP patients, which involves more than one major or more than three minor. And our patient, as you know, had one major plus multiple minor criteria. So naturally, this patient also required ICU admission. Now, investigations for a severe CAP include, of course, the entire microbiology. So you send your sputum for gram stain and culture, blood culture, 2 sets. Then if the patient is intubated, you send the ET secretions, bronchoscopy if the patient is intubated and if it is indicated, multiplex PCR if it is available, one, and two, if sending it is going to change your decision or it is going to bring about a change in your management. And of course, sending the pneumococcal and Legionella urinary antigens. So chest X-ray is usually enough initially. CT scan only if there's a diagnostic uncertainty or you're thinking of complications. These days, with the availability of ultrasound and majority of the Indian ICUs as well, it is easier to quickly put in your probe on the bedside and look at and examine your patient with the ultrasound, because that gives you a lot of idea. It will tell you about effusion, it will show you the consolidation, and quickly you can accordingly plan your management. And of course, you send in the influenza and COVID tests if if you're suspecting the viral infections to be there. And procalcitonin and CRP, we have discussed quite extensively in the previous modules as well. They support de-escalation, not the antibiotic initiation. Rapid diagnostics are only useful when, like I said, if they change your plan of management, if they change your decision, and they have to be available, and you need to know how to interpret them correctly. Only then rapid diagnostic tests are useful in sending. Then what would be the initial treatment for severe CAP look like? So you need to recognize complications, you need to recognize the severity, look at your patient, rule out sepsis, hypoxemic respiratory failure, whether the patient requires oxygen, non-invasive ventilation, or needs to be intubated. You've started you've sent in the appropriate microbiology that we just discussed and started the patient on empirical IV therapy. So the backbone of severe CAP without resistance is basically your beta-lactam, which can be ceftriaxone, cefotaxime, coamoxiclav, or even ceftaroline, plus a macrolide or a doxycycline. These days, more and more doxycycline is being used. And you cover for MRSA and Pseudomonas only with the risk factors. And then, of course, you manage the septic shock, the hemodynamics with the appropriate vasopressors and fluids as required. Start oseltamivir early if you are suspecting influenza rather than waiting for your PCR reports. And source control always remains an important aspect of treating your patient. So if you are, you need to look for empyema, abscess, or if there is an obstruction, all this would depend upon your patient. So you need to accordingly search for these and manage them appropriately, because source control is equally important as uh, starting your empirical cover. So when do you add MRSA cover? When there is a prior MRSA infection or colonization, post-influenza, there's a severe deterioration, cavitation, necrotizing pneumonia or hemoptysis, recurrent skin soft tissue infections. So the choice of drugs is vancomycin or teicoplanin or linezolid and clindamycin when toxin-mediated disease is suspected. When do we cover Pseudomonas or resistant gram-negative? Pseudomonas when there is this underlying structural lung disease, bronchiectasis, a patient with very severe COPD with repeated antibiotics, prior Pseudomonas isolation, if the patient is requiring invasive ventilation or is on high-dose vasopressors. The treatment options are piperacillin, tazobactam, cefepime, ceftazidime, or carbapenems when ESBL or septic shock is the risk. Now, adjunctive therapy. A little bit about steroids, whether to use or not. So, routine steroids are not recommended in community-acquired pneumonia, regardless of the severity. Stress dose hydrocortisone as per the Surviving Sepsis campaign for refractory septic shock. In influenza pneumonia, they're associated with increased mortality. And for COVID-19 pneumonia, as per the recovery trial, dexamethasone had shown to reduce mortality. So there was a newer evidence, Cape Cod French RCT, which was just published in 2023. And they saw that hydrocortisone is a reasonable consideration in non-influenza, non-shock severe CAP requiring respiratory support. Briefly about atypicals, because we've been talking about atypicals. So we know that atypical cover is usually for Mycoplasma pneumonia, Chlamydia, and Legionella. So the presentation of Mycoplasma and Chlamydia is usually subacute, and that for Legionella would be more acute and severe. And treatment for Mycoplasma is with macrolides, doxycycline, or fluoroquinolone. Beta-lactams are not effective for Mycoplasma. And these days, of course, like I told you, even macrolides. And for Chlamydia, doxycycline, macrolide, or fluoroquinolones. And for Legionella, levofloxacin 750 or azithromycin. So duration of therapy. Recommended therapy for non-severe CAP is minimum 3 days, and for severe CAP, more than 5 days, but this has to be individualized based on the pathogen, the bacteremia, and the complications. Longer courses are required when you have infections with Staph aureus pneumonia, especially if there's bacteremia, Legionella pneumonia, Pseudomonas or Acinetobacter or resistant gram-negatives. More complications like abscesses, necrotizing pneumonia or empyema. Then, of course, endocarditis and meningitis complications. So do not prolong antibiotics for a slow X-ray clearing alone. Mild residual cough if the patient is doing well. CRP not completely normal despite clinical improvement. Sorry. So that was in brief about the management of community-acquired pneumonia. Remember, it starts from recognizing the presence, then assessing for severity, understanding whether you need to treat on outpatient basis or you need to admit. If you need to admit whether your patient is going to the ward or to the ICU, then deciding on the right empirical treatment of choice, reviewing your patient at 48 to 72 hours, and then, of course, looking for uh, any complications is associated, and always remembering that source control in any infection case is as important as starting your empirical antibiotic therapy. Now we'll talk about approach to non-resolving pneumonia, which was taken by Dr. Deepak Talwar sir, and he had shown some very interesting cases. So we will just understand how do you approach a non-resolving pneumonia. So before non-resolving, what is a resolution? What do you mean by a normal resolution? That, as per the microbiology, the bacterial load starts to decline. Patient is getting clinically better, which is, I think, one of the most important parameters for assessing response. And of course, the vitals and the markers are also improving. Radiology, remember, it is last to clear, and sometimes it takes 4 to 10 weeks or even longer. So don't just depend upon the radiology alone. And if the patient is getting better, continue and stop your treatment once the symptoms have resolved. No need to treat the X-ray alone. So what is a no response at 72 hours? That is no improvement, that is absence of clinical improvement within 48 to 72 hours despite appropriate empirical therapy. Persistent fever, tachycardia, tachypnea, patient is requiring oxygen. Biomarkers are not falling. We often talk about biomarkers and them not being very helpful. So remember, the trend of biomarkers can help you understand the response to treatment, but not the initiation or deciding on changing of antibiotics. And deterioration at any time. So if the patient is worsen, if there's a worsening oxygenation, is becoming hemodynamically unstable, the radiology is worsening, and so then, you do not need to wait for 72 hours. You need to act there and then if there is deterioration at any time. So, like I said, do not treat the radiology, the chest X-ray, and the CT scan alone. Certain uh, bacteria in certain conditions themselves take a very long time to clear. So, like I said, minimum 4 to 10 weeks for clearance, and sometimes it even takes longer. So, it has to be a very combined approach to understand whether the patient is actually getting better or not, which would depend a lot on your clinics and how the patient is improving, what are the symptoms, and whether your treatment has been appropriate or not. So, what should improve? Like I said, patient should be improving. So, he should be afebrile. If he's having a persistent fever or a new onset fever, then, that's a red flag. You need to look and search for uh, what you've been treating, and do you need to change your treatment? Similarly, patient has tachycardia or worsening tachycardia, his tachypneic or starts to develop increased work of breathing, worsening hypoxemia, worsening PF ratios, increasing oxygen demand, hemodynamically becoming unstable, requiring more and more vasopressors. And of course, imaging and biomarkers will support this. So, if your biomarkers are rising, that does not only mean, or they are not going down, does not mean that your therapy is not effective. So, don't just rely solely on biomarkers as well as imaging. Of course, if the imaging is worsening, then accordingly, you have to reevaluate and look at if you have achieved source control or not. Now, the causes for non-resolving pneumonia can be understood under 5 headings. That is the host, the bug, the drug, complications, and the mimics. Now, group 1 is re-evaluating the host. So these factors, the host factors may slow recovery, but also increase the MDR risk. What are these factors? Advanced stage, poor physiological reserve, patient with underlying severe COPD, structural lung disease, bronchiectasis, immunosuppressed host, patient on long-standing steroids with a history of alcohol use, malnourished, poor lung function, has a long-standing indwelling catheter. So you need to relook at the patient first and see why there is non-resolution of his symptoms. Then reevaluating the bug. So, the organism that you initially thought or you're treating with may not be correct, or the drug that you have thought of for that specific antibiotic, maybe there is a failure to follow the guideline therapy. There is an atypical picture which you've not covered, or there are GI or CNS features. There could be, we've talked about post-influenza infections. There can be a history of travel or occupational exposure or endemic exposure. Like in certain parts of India, we have melioidosis. So, when you are treating a patient, you need to remember these aspects and accordingly cover them in your empirical therapy. And of course, the underlying immunosuppression. So, remember that you must think of opportunistic diseases and not miss fungal infections. Ask the patient for any history of travel, any history of exposure, any unintentional weight loss. And if the patient is diabetic, you should think of histoplasmosis or endemic fungi. Patients with COPD, diabetes, prior antibiotic, or a persistent infiltrate, you should consider Cryptococcus or Aspergillus. And immunocompromised with diffuse infiltrates, consider pneumocystis cerevisiae or invasive aspergillosis. So you need to ask about occupational exposure, any exposure to bird dumpings, soil, any history of travel, any history of prolonged steroid use, or anything that has made the patient immunosuppressed. Then the third group is reevaluating the drug. So do not change the drug class when the real problem is the dose, the source control, or the wrong diagnosis. So was the regimen appropriate for the severity and local epidemiology? You cannot forget the local epidemiology. You cannot forget the local antibiogram. You have to keep all these things in mind before starting your therapy. Was the dose optimized for renal function, obesity, augmented clearance? uh, the pharmacokinetics and dynamics. Does the drug penetrate the site? So the drug that you've thought, we've talked a lot about this, that the drug that you're giving your patient, does it actually penetrate that site to treat the infection or not? And did you delay the therapy? Was it interrupted, or is it that the drug is not getting absorbed only? So all these things need to be reevaluated and kept in mind when there is a non-resolving pneumonia. Then group four is look for hidden source failure. Like there could be an empyema or loculated diffusion. So you might have to drain it and do pleural fluid studies for your patient. There could be a lung abscess or necrosis, which would require maybe a repeat CT scan or a new CT scan, and patient may require prolonged therapy and even drainage. For cases with obstruction, you might have to do a bronchoscopy. And if there's an aspiration focus, first and the foremost in an aspiration focus is that you need to prevent aspiration from occurring further. So you need to protect the patient's airways. So, uh, if the patient, that there is a risk factor, there's a possibility that this patient is aspirating, then, stop feeding him orally, so secure in a Riles tube. And then, of course, do the swallowing evaluation to understand that whether there is actually an aspiration focus, which is resulting in repeated or non-resolving pneumonia. Imaging strategy essentially remains the same. So, chest X-ray is usually useful and usually don't require further imaging, but there can be retrocardiac and subdiaphragmatic lesions which can be missed. CT thorax when there is a discordant with clinical cause. CTPA if there's a possibility of pulmonary embolism. Like I said, POCUS is very useful. It's a good bedside tool. So remember that usually imaging strategy remains the same unless you're suspecting something else. Then group 5 is that it looks like pneumonia, but it is not. So the patient could have a pulmonary embolism or an infarction, maybe an underlying malignancy, organizing pneumonia, drug toxicity, diffuse alveolar hemorrhage or vasculitis, and even eosinophilic pneumonia. So all this would be ruled out based on the presentation, based on radiology, and of course, based on the, you will have to investigate accordingly depending upon what you're suspecting. So these could be the mimics and why the patient is not getting better. Then bronchoscopy and BAL evaluation is usually in patients who have persistent or worsening infiltrate despite appropriate therapy. In immunocompromised hosts, of if you're suspecting an opportunistic infection, so you need to rule out tuberculosis, fungus, pneumocystis cerevisiae, viral and atypical infection in these patients. And of course, if there's a suspicion of diffuse alveolar hemorrhage without a sequential BAL and the subsequent aliquots becoming more bloody, you cannot diagnose this. So it would depend upon the underlying pathology. And when you are sending in your BAL, you need to send the stains, the appropriate cultures, CBNAT, fungal stain, even galactomannan and PCP, PCR and viral PCR and cytology. So all this needs to be sent if you have done your BAL for your patient. Then when is BAL not enough? When the infection suspected and the lavage cannot answer the question. So when you think of EBUS, when there is a node or a peripheral region which can be approached with radial EBUS, CT guided biopsy for a peripheral lesion, or if you're suspecting, a malignancy, fungal infection or an opportunistic infection, and VATS biopsy when all these modalities fail and tissue diagnosis becomes very essential. So essentially, it would all depend upon what you're dealing with and what would be the most appropriate investigation if you're not getting an answer with your bronchoalveolar lavage. So the algorithm to just review for the non-responses, you confirm whether it is actually true pneumonia and what is the severity trend. You recheck the host, recheck the bug, recheck the drug, look for the source of infection, control the source, consider mimics, and of course, for sampling and tissue, if it is needed, you do a bronchoscopy BAL, EBUS if it is appropriate, or biopsy when it is really needed. So, CAP management starts with the diagnosis, severity, site of care decision, and right empirical therapy. In Indian practice, you must remember TB, do not forget it. And of course, Klebsiella, gram negatives, influenza, and the local antibiogram always. At 48 to 72 hours, reassess the trajectory, look at the patient's presentation, look at his symptoms, hemodynamics, oxygenation. Non-response does not automatically mean that you need to shift or move or put the patient on stronger antibiotics. You need to use the host bug drug complication and mimic framework to rule out the possibility why there is no response. And of course, CT scan, focus, bronchoscopy, BAL, and biopsy should be used when the story does not fit. So radiology, like I said, clears last. Persistent opacity alone is not treatment failure. De-escalation, source control, and correct diagnosis are as important as initial antibiotic choice. Thank you.